now go on to our last very dynamic speaker, Dr. MS Ravindra, and he's going to be telling us, giving a special lecture on nuances in planning a premium IOL in MSICS. We look forward to a very interesting talk from you, Dr. Ravindra.
Do you see it now?
Yes, yes.
Fine. I just asked my staff to give me the analysis of last 1,000 MSICS done in our hospital. And I myself was surprised to see the results. Of that, 32% of all the surgeries, including charity surgeries that we do or low-cost surgeries that we do, 32% are multifocal lens and 68 are monofocal.
Fine.
Fine. Okay, now 32% are multifocals of all the surgeries. And if you look at the monofocal lenses, we have 1:2 ratio of imported and Indian lenses. We like Indian lenses a lot, but some people insist on imported. When you look at the Indian versus multifocal of the multifocals, we have a strong priority for Indian multifocals that 90% of our 90% are Indian lenses, while only 10% are imported. This is what I would like to drive, that the quality of Indian multifocals are extremely good these days, and many times they're better than imported lenses. This point I would like to drive very strongly. And that's the difference between multifocals, imported, monofocal, all of them. But I'll come to the status. Last Indian multifocals versus imported monofocals. That is, these are premium patients who ask for premium lenses. Of that, 40% of them opted for multifocals as compared to monofocals, which are imported. So that 60 to 40 ratio approximately indicates that there's a strong priority for me to choose in multifocal lenses as against the premium monofocal lenses. Monofocal also includes EDOF lenses, EDOF and monofocals, which are highly priced. When compared to that, 40 to 60 is that shows how much of bias I have for implanting multifocal lenses. And LRI, the main advantage of SICS is control of astigmatism. The LRI is only 2%. See, you know that there is a range of astigmatism that we need to cater. With that, can be catered with the SICS itself, modifying the wound. So LRI, that's necessary only in a very small percentage of our patients. Is that video visible?
Yes.
Fine. So I would like to show a video wherein the patient had an astigmatism. I had to choose a multifocal. Patient opted for a trifocal lens, and then I marked it. These markings are done using the various ways of marking the cornea. We use multiple markings, slit lamp markings, as well as vessel marking. This vessel can be identified on our optical biometer, and we mark it, and then we confirm the exact axis of placement by multiple methods, slit lamp as well as by the optical biometry. Then this is the technique that I would like to prefer. I start with a 2.8 millimeter keratome, 1 millimeter away from the limbus on the steep axis in this particular patient, which is horizontal placed. Inject a small amount of visco. It's not deepening the anterior chamber. Tunnel floor entry technique, which I often tell you, the entry is at the limbus, and I do a rhexis. The tunnel is not leaking, as you can see here. So the depth of the anterior chamber is maintained perfectly, and I can do a reasonably good rhexis. I'll go a little fast to save time. So that's pupil is dilated to about maybe 7 millimeters, and I've enlarged it to 5.12 millimeters, and I'm enlarging only the anterior aspect of the tunnel. This reduces the endothelial loss, as my observation is done in follow-up of these patients. So, the hydrodissection, rotate the nucleus, prolapse the nucleus into the anterior chamber, and extract it under a continuous inflow of viscoelastic in front of the nucleus to separate it from the endothelium, as you can see there. a microvectis is a small vectis. This diameter is only 3 millimeter and about 8 millimeter long, and each heminucleus is aspirated. So what is happening is the technique involves least amount of capsular handling. There's nothing happening inside the capsular bag. The moment you've gone inside, you prolapse nucleus out of it. So capsular bag, even if there is a deficiency or even if there is a zonula weakness, it's not hampered. And the second is maximum endothelial protection because of continuous visco injection, as well as the phacoenergy itself can, though there are the modern techniques will minimize the loss of endothelial cells, the maximum endothelial protection happens in this particular patient. The only thing that is questionable in SICS is the amount of astigmatism you're going to produce. If you have a tight control on the astigmatism by various techniques that are explained periodically, especially by Dr. Boramani, then it becomes pretty easy to control your astigmatism. So this particular technique will produce half diopter of SIA, which I take into calculations. The toric trifocal IOL, which I am aligning on the axis that's necessary. It's very important to remove the entire viscoelastic from the capsular bag. You have to wash it thoroughly, and entire viscoelastic from the anterior chamber is eliminated so that the lens does not rotate after that. You can see faint marks that are made on the cornea, and the alignment of the axis will be made in that meridian. So patients have been extremely happy. The two things that you'll have to titrate before you decide doing a surgery on SICS is amount of endothelial protection you're going to do, amount of SIA you're going to produce, and that is the axis, and I'm going to align it to that axis. And generally, I ask the patients to lie down for about an hour's time so that it doesn't wobble during the post-operative moments. That's the end of surgery. So what I was trying to, there's another case. Is that visible, Dr. Chitra?
Yes.
Fine.
Yeah, we do.
This is a case where there is a posterior capsular question mark subcapsular cataract, and we can still go ahead with the things that we generally don't do in a phacoemulsification. That is capsular separating hydrodissection and nuclear rotation are generally not performed. But in this technique of low fluidics, the pressure in the eye is very low. It's atmospheric or less than atmospheric, and fluidics is very, very gentle. And you can do a hydrodissection segmentally, as you can see here. You can see a central mass there, and when I do the hydrodissection, it's a capsular separating hydrodissection. You can see the mass getting separated from the posterior capsule. This is segmental. I'm giving very tiny jets of the capsular separating. You can see the entire thing is separated now, as you can see there, and there is a bare posterior capsule. And now if I pressurize the anterior chamber, this bare posterior capsule can give way. So the low pressure technique is one which is very ideal. I am rotating the nucleus to separate all remnant of attachments, prolapsing it to the anterior chamber. And here is an advantage of a low pressure technique or a low flow technique, low fluidics technique over high fluidics technique, where you're not ballooning the posterior capsule backwards, putting it on tension. The other thing you can notice is the AC is absolutely shallow. It's shallow. There is a risk of endothelial damage, so I'm going very carefully with repeated injections of viscoelastic. There's no stretch on the posterior capsule. If you stretch the posterior capsule backwards, as it happens in a high pressure, high flow technique, and there is a possibility of tear. So I've done hundreds of these cases, and not even in one case I've torn the posterior capsule. So I'm very confident that I can give any kind of lens. So this patient has opted for a multifocal. You can see here, once you remove the posterior capsule, the pressure on the posterior capsule gets equalized, and the risk of posterior capsule dehiscence is minimal. So now I'm aspirating the cortex. The fluid that you need for the entire surgery is only about, on an average, about 30 milliliters of BSS. You don't need more fluid than that. The flow is very, very gentle, very smooth. And then you put a multifocal lens into the capsular bag. So multifocal lenses and toric lenses can be offered in SICS, provided you know how to control your astigmatism and you know how to protect the endothelial cell maximally. Otherwise, whatever technique that you use, ultimately you need to give a good emmetropia to the patient who is opting for a multifocal or a specialized lenses. I think because of short of time, I can end it here, Chitra.
Yeah, yeah. Wonderful, wonderful videos and wonderful, wonderful explanation everywhere. Um, uh, Dr. Deepak, may we?
Dr.
Yes.
Dr. Ravindra, what you have said exactly, I want to say, we are presenting a paper recently, toric IOL in SICS. Because
I just wanted to ask you this question only. Is there any special tip which you have to say when you are implanting a toric IOL in a SICS case?
Yeah, Dr. Chitra.
Yes.
There are two things important in toric IOL. Number one, when we take the IOL power, we take the site of the incision and the SIA. Everybody knows it. In SICS, when we are doing, everybody knows their astigmatism. I do incision at 6 millimeter incision at 90 degree, and I produce 1.25 millimeter astigmatism. Okay, so I know my SIA. So in toric IOL, what I am doing in SICS, we are keeping the site of incision 90 degree. We are keeping the incision size 5 millimeter. We know it will produce 0.75 or 1 millimeter astigmatism, diopter astigmatism. So we are keeping our SIA 1 diopter. In place of 0.25, normally we do in FACO. Site of incision 90 degree. And we have done more than 20 cases of toric IOL now in SICS with very good results, 6/6 by 9 result. So you have to calculate SICS as per the estimate you are going to produce by the incision. At this site, you are going to give it.
Dr. Boraman, your thoughts?
Yeah, he's absolutely right. Surgeon should know what type of astigmatism is produced by your type of incisions. And if you are very confident about the surgically induced astigmatism, you can put it on the net on the various formulas, what the amount of surgically induced astigmatism, and you can put very well a toric IOL. But here I want to say that my use of toric IOLs is progressively reduced. I use toric IOLs for a very high astigmatism because most of the astigmatism, even up to 2.5 diopters, can be neutralized very well with your own incision. I got my own nomograms and they are working very well, at least in 90% of the cases. So the amount of toric IOL cases are very much reduced.
I
and I also
agree.
like.
Very good. I agree, sir, with you. But problem happens, sir, only when the incision site is not approachable. Then we have to put toric. Otherwise, you can control by SICS by incision all the toricity. This is the beauty of the SICS. This is beauty of the.
Is the steep axis is horizontal, then it is difficult to neutralize more than 1 or 1.5 diopters of astigmatism. Sometimes I used opposite CCI in such cases, SICS incision temporally and clear corneal incision nasally. That also works very well. And I am putting a lot of premium lenses like Dr. Ravindra. I am not into charity practice also. But if you are confident about your astigmatism, then you can put a lot of premium IOLs in SICS also. Even I hate calling it as a SIA because I call it always as a SCA. It is a surgically corrected astigmatism, not a surgically induced astigmatism. Because surgically induced is unwanted pregnancy, surgically corrected is a planned child. And here I want to make a comment, no financial interest, but now we have got beautiful progressive IOLs. These are the only IOLs of kind available in the world, which are varifocal IOLs. Varifocals are very well available in spectacles, but not in intraocular lenses. Now it is the innovation of Dr. Jagdeep Kakade and Dr. Ramesh Shah. They are Indian lenses, excellent lenses, because whatever bargaining you are done, like with all the multifocal IOLs are having multiple rings and their inbuilt problems like halos. The EDOF also is without ring, but in EDOF you have to do little compromise between the two eyes. One eye you have to adjust for distance and intermediate, second, intermediate, and near, because the range of focus is not full. But this progressive eye, the autofocus lens, is giving a full range of focus right from distance to near and without any rings. So there is no financial interest, but I think these are the excellent lenses and they are available in India. And I can call them as a super premium lens.